Hi, my name is Jason Holm, and I'm a fellowship-trained orthopedic sports medicine surgeon here at Twin Cities Orthopedics. Today I want to talk a little bit about ACL injuries, focusing specifically on some of the rehabilitation strategies that we try to employ here at our rehab department, and also really focusing on injury prevention and some of the programs that we have in place for that. So ACL injuries, we know it's a very common problem occurring up to around 200,000 times a year in the United States, affecting our athletes. It's a very challenging injury, as a lot of you probably know, for our athletes to recover from, not only in regard to returning to their sport, but also in regard to some of the long-term consequences that can happen from these devastating knee injuries. Fortunately, we are able to get most of our athletes back to participating in sports by reconstructing their knee. Most athletes, if they want to do cutting and pivoting sports, they usually need to have the ACL reconstructed. Recently, due to a variety of factors, we certainly have seen ACL injuries be on the rise. In fact, it's becoming a little bit of an epidemic in our young athletes especially. And obviously, given the long-term consequences of these injuries that we can see on the knee, certainly there are things that we need to do as surgeons and as physical therapists to try to modify some of the risk factors for our athletes so that we can help prevent these injuries. One of our biggest concerns for our athletes certainly is the development of arthritis. And we know that tearing an ACL, no matter if we reconstruct it or not, certainly our athlete is at increased risk for developing arthritis in the future. I recently had the opportunity to see a late 20s athlete in my clinic who had played Division I college football. He was a running back. He tore both of his ACLs. He had them reconstructed. He was able to get back and play. And initially he did really well. And this is unfortunately, sometimes the consequences that we see of an ACL reconstructed knee now just a handful of years later, where for those of you who are familiar with x-rays of the knee, certainly we're seeing a lot of what we call marginal osteophytes, joint space narrowing, and this is all in the setting of an ACL reconstructed knee. And for an athlete in their mid-20s, this can be very devastating with ongoing pain, swelling, limitations regarding the activities that he wants to do. And unfortunately, this young athlete likely at some point in his life will require a knee reconstruction. So that's the kind of thing that we're trying to avoid by incorporating appropriate rehab strategies and injury prevention here at Twin Cities Orthopedics. Young patients who tear their ACL are at particular increased risk of re-tear. A recent study showed that over the course of 15 years after a young patient tears their ACL, the chances of them re-tearing that graft after a reconstruction or tearing the ACL on the other knee is over 33%. So over a third of our athletes are going on to re-tear of their ACL. So this is something that certainly we as orthopedic sports medicine surgeons here at TCO and in our rehab department are trying to change these numbers and change these trends and see what we can do through better surgery, better understanding, better rehab techniques in order to prevent these recurrences. We believe that the first step in injury prevention and re-tearing of ACL grafts is to identify what the risk factors are. So what are the risk factors for tearing an ACL? We can talk about a variety of different factors. Certainly just participating in high energy cutting, pivoting, sporting activities, basketball, soccer, football, those are just activities that place the knee at high risk for having an ACL failure. In addition, there are a variety of anatomic risk factors. When we look at the knee, we know that some of the risk factors, looking at the ACL, or the anterior cruciate ligament in the center of the knee, some of the risk factors included a narrowed notch, and that's just something that people are born with. Women in particular tend to have a more narrow notch. Sometimes the slope of the tibia in this direction can affect the ACL. The ligaments on the outside and the overall laxity of the knee can be a factor. There are genetic factors, and gender is a risk factor. Women in particular have a 3 to 8 time increased risk of ACL failure participating in cutting and pivoting sporting activities. So the next question we have to ask is, what are some of the modifiable risk factors? What things can we do as surgeons and therapists? And then how can we implement strategies and put people through a program to hopefully prevent re-tear or injury in the first place? So let's meet Katie. She's one of my patients who unfortunately tore her ACL while playing lacrosse. She had a non-contact pivoting injury to her knee that led to an ACL tear.
I tore my ACL. It was the middle of May. I was running down a lacrosse field. I shot the ball at the goalie. My knee came in, but all I remember is going down, and then I was on the ground and I was screaming. I wanted them to stop everything. I heard a pop, I felt everything, but I honestly didn't know what anyone ever said about an ACL because I didn't know. I knew people that tore their ACL, but I never talked to them about it.
All right, so here's the first day when we tested you out. So we did a bunch of different tasks. So we kind of went through each of these videos and we're just looking at the different things. So on here, it's your double leg jump. So from the front view, you're looking at the knee angle, right? So you're trying to watch kind of the hip to knee to foot.
Okay.
So really this looks fairly good.
It like slightly goes in on that knee.
Yeah, and you have a little wobble over here.
Yeah.
Again,
Yeah.
slight, right?
Yeah.
So this is where you can really see on your side view how your legs don't go equal. So then here you can watch your feet are super different. So you just have different heights. You have different heights of hip flexion and knee flexion in this jump. So you can just tell that it's very different. So we look at that and then we compare it to the last video. And again, so we're looking at your hip level, we're looking at your hip to knee to foot. You're looking at the total depth that you're doing it. So here you're just landing. I mean, it looks a lot more solid. So you go to the side view and you watch this. It just looks, again, more solid. If we go frame by frame.
Yeah.
Darn near equal. So much different than that first time when you had that, again, the difference between the limbs, which means you're using them different. The power that you're using to jump is unequal, which is where injuries happen, is because if you're not utilizing both limbs equally or you don't have that confidence to utilize both limbs equally, you're going to end up in trouble with an injury.
Katie certainly had some of the risk factors that we just talked about that kind of placed her at some increased risk for going on to tear her ACL. So those are the kind of things that we wanted to address. What are her risk factors? How can we modify them? How can we not only help to protect her knee from tearing the graft that was put in, but also how can we prevent her other knee from going on to have injury? So in her surgically operated knee, we took a central portion of her quadriceps tendon. We reconstructed the ACL with that tendon. It's a nice beefy graft structure that very closely simulates the native structure of the normal ACL. So she's done very well. She's worked very hard. We're going to look at a little bit of video of what she's going through our ACE program here at TCO and kind of talk about some of the benefits of doing that program. So when we look at our female athletes in particular, as well as our male athletes, looking at some of the risk factors, we know that a relative increase in quadricep strength relative to the hamstrings can be an increased risk factor for ACL injury. This quote-unquote quadriceps dominance is important in sports that involve high-risk activities like running, cutting, pivoting, and jumping. In addition, when compared with male athletes, female athletes often demonstrate increased lateral trunk motion, more of a knock-kneed alignment, increased rotational instability, and this places athletes at increased risk for non-contact ACL tears. So these non-contact ACL tears are really what we're trying to target, because approximately 70% of all ACL injuries occur as a result of a non-contact. Things like landing from a jump, forcefully decelerating, cutting, pivoting over a planted foot, and these are all things that are theoretically we can modify in order to prevent ACL re-tear. One of the main modifiable risk factors that has been identified is what's called knee valgus collapse. So when we talk about doing injury prevention programs, we're talking about modifying the ground reaction forces. Basically, when an athlete is jumping and landing, how are their knees coming together or staying apart? What is the hip flexion angle? What's the knee angle? And are there ways that we can incorporate rehab program that helps to prevent these bad mechanics that place athletes at risk for ACL tear? These training programs should incorporate balance, strength, trunk strength training, plyometrics, and really focus on proper landing techniques, specifically increasing the separation between the knees when an athlete's landing. And these have been shown to be the most successful programs when it comes to reducing the risk of ACL injury. Of course, compliance, consistent effort are critical for success. Ideally, the athletes would not just be doing this intermittently, but would actually make this a bit of a lifestyle in regard to the way that they warm up and the way that they focus on their mechanics. Ideally, that would be 10 minutes, at least 3 times a week, A recent study showed that positive effects you can have for ACL injury prevention can be diminished if an athlete just stops doing these programs. So after 6 months, they might revert back to some of the same landing techniques that they were using before, and unfortunately go back to the same level of risk they were at before. So for someone like Katie, again, we have to kind of talk about what are the risk factors in particular for re-tearing an ACL that's been reconstructed. So again, returning to a high level, cutting, pivoting, sporting activity, certainly that's the biggest risk factor. Just being out there, being exposed to a lot of rotational energy to the knee. Unfortunately, we do know through our research that the vast majority of time, re-tear of the ACL is actually due to poor surgical procedure, poor technique. There are a variety of different things that have to be done appropriately. You have to select the appropriate graft. It has to be appropriately sized. It has to be appropriately positioned in an anatomic fashion that matches what the native ACL is trying to do to constrain the knee. Oftentimes there are concomitant injuries, such as injuries to the meniscus, that also provide a little bit of stability from a rotational standpoint to the knee. And there are injuries to the ligaments on the outside. All of these things have to be addressed at the time of surgery. And if that's not done, what will happen is there will be ongoing increased stresses on the ACL graft that's been put in place. So when an athlete tries to get back in activity, they're actually at increased risk for tearing that graft no matter how well it was put in place. Another significant risk factor for failure of an ACL graft is incomplete rehabilitation. And this is something we spend a lot of time researching and evaluating. We do know that the maturation of the graft actually takes 12 to 18 months before it reaches its full strength. Another really important factor is regaining neuromuscular control. So the nerves and muscles are firing together to control the body's movements, and we know that that can also take a year or two, so up to 2 years to reach kind of its maximum potential so we can get our athletes back. Does that mean that our athletes can't return before 18 months or 2 years? No, it certainly does not mean that. It just means that we have to be very diligent about maximizing our strengths, maximizing what we can do from a rehab standpoint so that our athletes are ready to get back, so that the graft is not seeing a lot of excess load and the rest of the body is working to protect the graft. At Twin Cities Orthopedics, we have multiple programs in place working to prevent ACL injuries and also working to prevent re-tear of our ACL grafts after surgery. Really, we're working hard to get our athletes back to the same level of competition they were at before, or ideally even a higher level of competition they were at before. Katie is certainly an example of one of those athletes who's worked very hard. We were able to see great strides from the start of the program. When she started with the ACE program, we were able to watch her mechanics change, watch her confidence improve, watch her strength build, and those are all things that I think absolutely are going to allow her to get back to being competitive in lacrosse this year. I'm very excited for her upcoming season, so good luck to you, Katie. If you want to hear more about our programs at TCO, you can visit our website at tcomn.com. Click on the sports performance link. You're certainly welcome to contact our department if you'd like to get any more information. Thank you.